Hey everyone, it's Steve. I have a quick presentation to share with everybody. This is a presentation I did at the Y just earlier this week. We're going to chat about a bunch of shoulder stuff. We're going to chat about essentially looking at the shoulder anatomy, some of the things we see in clinic or common injuries, and kind of get into some rehab and 5 of my favorite shoulder exercises to keep your shoulders strong. And for those of you that don't know me and that don't know Peach Physio, the clinic, we are a clinic of physio, pelvic health physio, chiro, massage. We offer concussion care, vestibular care, radial shockwave, custom orthotics, acupuncture and dry needling, custom bracing. We offer a pretty wide array of rehab services and products. We're in Chatham, right on St. Clair Street. We moved to a new location a couple of years ago. We just have a couple of pictures here. Now, me personally, I'm from Chatham, born and raised. I graduated from the University of Western Ontario with a Master's of Physical Therapy in 2012, and I opened Peach Physio in 2014. So the pictures you guys are seeing are my 2 wonderful kids, Isla and Brooks. This was Isla's first day back at senior kindergarten this year. So just a nice picture for you guys to take a peek at. Now, like I said, we're going to kind of dive into shoulder anatomy and look at some of the complexities that make up the shoulder. The 2 common injuries we'll really focus around are going to be rotator cuff issues, whether that's what people used to call like tendonitis, or looking at rotator cuff tears as well. And then the other side of the coin that we'll look at injury-wise is going to be frozen shoulder, which is something pretty common that we do see in the clinic. And there's a lot of good information we can share about that. We'll chat about rehab. Really, the rehab focuses on rotator cuff injuries. I'll touch briefly on rehab for frozen shoulder. But that's a whole nother ball of yarn that we could do another video about. Then the last part, we're going to chat over 5 of our favorite shoulder exercises to keep your shoulders strong and healthy over time. So we'll kind of jump into anatomy. I'm going to close this out and actually pull up this app.
All right, so everybody should be able to see this anatomy app. Now, we're going to look at a few different parts of the shoulder so you guys get an idea of why things move the way that they do. So looking here, we can see right through, we see the ribs, we see the sternum, we see the spine, so part of the thoracic spine, or the thoracic spine and up into the neck. If we look through the rib cage, we can see the shoulder blade, see the collarbone, and then the humerus, or the upper part of the shoulder. So in here we see the ball and socket joint. Now, when we talk about the shoulder, it's more than just the ball and socket joint that makes up movement. When we reach all the way up above head, part of the movement does happen from the ball and socket joint rotating, but some of that movement also happens from the shoulder blade rotating upwards on the rib cage, and even from the collarbone rotating upwards and backwards as we reach up. Now, if you reach straight up above head, it should be fairly easy. If you hold your shoulder blade down, so kind of push down at the top of your shoulder and reach out to the side again, it'll feel much, much stiffer and you won't be able to move near as much, which gives you a pretty good idea on the importance of the shoulder blade rotating upwards when we try to reach overhead, which is one of the big reasons why a lot of the times when we see patients in the clinic with shoulder problems, we do a lot of strengthening around the shoulder blade as well, and we work on some mobility for the shoulder blade and through that mid part of your back too. Now, if we start adding layers of muscle here, we're going to see the rotator cuff pop. And when we say rotator cuff, it's a term that most people have heard, but really most of the time we don't know exactly what that is. And what the rotator cuff is, it's a term for 4 muscles that start on the shoulder blade and wrap around to the ball and socket joint. So when we look here, we have the first muscle, the supraspinatus, it's highlighted. The infraspinatus now should be highlighted. The teres minor. And at the front of the shoulder blade, wrapping around the very front of the shoulder, is the subscapularis. Now, what these muscles do is they try to keep that ball and socket joint strong and stable. Now, ball and socket joint isn't a nice deep socket. It's more of a golf ball sitting on a golf tee. So think of it that way when we think of this ball and socket joint that makes up the glenohumeral joint. Now, we see the rotator cuff, but if we keep adding layers of muscle, we see that there's other muscles that cross the shoulder. Okay, so there's the coracobrachialis, which helps lift the shoulder straight forward. We start getting into we see some of the muscles that actually start on the shoulder blade and wrap around to the ribs. We see this teres major muscle, and then we start adding in biceps. So those two muscles actually do cross the ball and socket joint or cross the shoulder. And then we start getting into the very big muscles like our pec, 3 heads of the deltoid. And what isn't pictured in this model are all the muscles that go from the shoulder blade and up to the spine, or other muscles that go from the shoulder blade to the rib cage. Now, take some muscle away so we can look at some of the connective tissue around the shoulder. So there we see that ball and socket joint again. Now, when we add connective tissue, we start getting into the joint capsule, or the connective tissue directly around the shoulder. We start seeing ligaments. Some of the ligaments go from the shoulder blade to the head of the humerus, or the ball part of the ball and socket joint. And we start getting into muscles that also connect, ligaments that also connect from one part of the shoulder blade to the next, or from the collarbone to the shoulder blade. And we then look at some of the bursas, or the small fluid-filled sacs around the shoulder as well. Okay, so it gives you a really good idea of how complex the shoulder is, both because there's lots of muscles that control it, but also there's a lot of moving parts. So part of that is the ball and socket joint, but also the collarbone and the shoulder blade rotating on the rib cage. So hopefully this provides a little bit of kind of makes things a little bit more kind of understandable why strengthening both around the shoulder directly and also around the shoulder blade and working on mobility in those areas is really important.
All right. So let's go back into the presentation here. Now, like I said, we're going to touch on 2 main injuries that we see a lot. Rotator cuff pain is a pretty broad term, but we're going to spend a bunch of time on that, and then we'll jump into stiff shoulders. Now, if anybody's had rotator cuff issues in the past, this will sound pretty familiar. Usually rotator cuff pain is pain reaching above head, reaching away from the body, trying to scratch your back. 3 of the muscles externally rotate the shoulder, so when we internally rotate to reach behind us, stretching those muscles can usually be painful. And oftentimes people will say that it's painful to sleep on that side. These are the usual things that we're looking for when people come in with rotator cuff pain. A lot of the times we really don't know what started the pain, or why it is going on exactly. It'd be nice if we could easily say that there was one instance that caused the pain, but that's really uncommon. Now, we'll get into this this concept of tendinopathy, which is basically saying that there's some kind of pathology to the tendon. Okay, now when we simplify that a little bit more, really a tendinopathy is irritation of the tendon. Now, we'll also talk about partial and full thickness tears, and tears are really more of a defect. There's an actual break in the tendon. So there can be irritation and there can be defects. Ultimately, our treatment actually isn't that much different between the two, but we'll jump into that part too. All right. Now, tendon problems at the simplest form come down to overloading the tendon. Now, overload can mean a lot of different things to a lot of different people. We take, for example, a professional baseball pitcher, and what's overload for him or her is going to be very different than what's overload for somebody with shoulder pain who hasn't played volleyball in 6 years. They play in a full tournament and friends over the weekend, and then on Monday they need to paint the ceilings in the house. Okay, overload can be very different to different people. We can also have overload with a traumatic single event, for example, falling on your arm. That's a case where the injury can happen very specifically. But at the simplest concepts, overload is what can create some of the problems within the tendons, and ultimately lead to pain for some people. Now, another thing that we talk about with overload is, how do we keep our tendons strong? Now, people that maybe don't move much or don't do a particular movement very often, they can develop some stiffness and weakness in some of their soft tissues, which makes them a little bit more susceptible to overload, which is why it's really important to stay moving, continue strength training, continue doing stuff overhead, so we keep strong, resilient tendons and muscles. Now we'll get into looking at tears. Now this is a really good slide, just kind of getting and touching on into the fact that rotator cuff tears are really, really common. Now this is brings a bunch of research together, looking at the prevalence of full thickness rotator cuff tears in people without shoulder pain. All right, so you can see in this graph that by the time people are about 55, there's anywhere from up to maybe about a 20% chance that they have a full thickness rotator cuff tear, but they still don't have pain. So the full thickness tears don't necessarily explain the entire problem, which is why they don't always operate on them. If the full thickness tear isn't causing limited range of motion, significant pain, then it doesn't make a lot of sense to go in and muck things up with surgery. Okay. Now, I wanted to kind of show you guys a little bit more about a full thickness tear. Now, if you think of full thickness tear, it's very easy to think of a rope that's completely broken and it's completely split in two. Now, I have this piece of raisin bread, which is going to be my educational material for full thickness tears. Okay. Now, if we imagine that this piece of bread is your tendon, okay. Now, when we have a full thickness tear, it's a tear from top to bottom in the tendon. Okay. Now, when we talk about the size of the tear, it's the distance from front to back. Okay. Now, if this piece of bread was your tendon, we technically have a full thickness tear. Now, I did tear it at the side of the piece of bread, but it could be a tear in the middle. It could be a tear on the other side. We still have the rest of this good piece of bread or good tendon in place. Okay. So when we hear full thickness tear, we have to dive a little bit more into the details in order to really get an idea if it's problematic. Okay. And that's when, your doctor, physio, chiro, surgeon would all be very good at figuring out if that's going on. Now, when we get away from full thickness tears, we start talking about partial thickness tears, and these are also really, really common. So this information in this graph is also for people without shoulder pain. And we look at, by the time people are 65, there's a 25% chance that they have partial thickness rotator cuff tear without shoulder pain. All right. So it's important, if you do have imaging, to kind of look at it critically and figure out, is this contributing to the pain? Is this something that has been going on for a really long time and it's just started bothering me? Or is this more of an acute injury? There's a lot of considerations when talking about rotator cuff issues. All right. Now, one time that they will do surgery, more often than not, is if there is a significant traumatic rotator cuff tear. Now, these are the people that fall off a ladder on their shoulder and afterwards they can't physically move their arm. Okay. Have significant pain. Clearly, something in that instance happened. Right. Now, I'm not a surgeon and I don't pretend to be one, but other things that they consider, when they're thinking about surgery, how strong was that muscle before surgery? Was it, was the muscle already very weak, and maybe the tendon was a bit brittle? So if we do go in and repair it, are we going to have better outcomes than not going in to tear it or not going in to repair it? So there's a lot of different things that they consider when we're looking at if surgery for rotator cuff tears is appropriate. All right. Now, this is kind of a series of events that explains kind of the evolution of rotator cuff or any other tendon problems. Now, we start over here, we have normal tendon overload, whether that is, like I said, a pitcher, a weekend warrior going to their first volleyball tournament in years and years, whatever the case is, we get this overload and we get this natural reactive tendinopathy. So the tendon gets a bit angry, it maybe gets a tiny bit inflamed, and we start to have pain. Now, if we don't do the right things, we end up having the tendon that doesn't repair itself as well as it can. So we start getting some breakdown in the tendon. Now, the unfortunate reality as well is as we get older, our tendons do break down a bit easier than when we're young. Okay. Now, as this happens, if we start getting breakdown and we don't do anything about it, we start getting more chronic tendon changes, which can ultimately lead to partial thickness tears, full thickness tears, and eventually bigger, massive tears. All right. Now, where we come in is when somebody has that reactive tendinopathy, we come in to try to settle things down and try to build them up to avoid that poor tendon repair and avoid as much breakdown as possible. Now, if somebody comes in and they've had shoulder pain for years and years, they may have some of that chronic tendon change, but we want to try to strengthen and minimize any further changes and try to make that tendon as strong as possible, and the surrounding structures as strong as possible to avoid any more serious partial thickness tears that turn into more and more as things evolve. Okay. Now we're going to jump into frozen shoulder. Now, talking about frozen shoulder, it's best to first talk about stiff shoulders. Okay. Now, there's a lot of things that can cause somebody's shoulder to be stiff. Now, frozen shoulder is what we'll focus on. And frozen shoulder is a very specific pathology that your body does to itself that we're going to jump into. But osteoarthritis in your shoulder can cause significant stiffness. A dislocation could cause obvious stiffness. And these would be people that would come into the clinic that maybe have had a sports injury or a car accident. So we don't see much of that. Large rotator cuff tears can cause stiffness. However, they're going to cause stiffness actively. So the patient isn't actively able to move their arm because they don't have the muscle to initiate the movement or to control the movement. If I grab their arm, I can move it no problem, but actively they're limited. If for some reason somebody has a lot of pain, they can be very guarded around their shoulder and limit range of motion. And sometimes there can even be referral coming from the neck that are going to cause stiffness around the shoulder. Okay. Now, like I said, frozen shoulder is a systemic condition. Okay. Now, with frozen shoulder, we see a limitation of range of motion, both actively and passively. All right. Now, external rotation, or having the elbow tucked in at your side and swinging the arm out, is the major one that we would expect with frozen shoulder. But somebody with a true frozen shoulder, they can't actively move their arm. And if I grab it, they completely relax. I'm not going to move it any further. Okay. Now, early in frozen shoulder, it can sometimes mimic other conditions, whether that's bursitis in your shoulder, a rotator cuff injury. So early in frozen shoulder, it can be a little bit difficult to identify. But as things evolve and as things change, we really need to kind of nail down if that is the diagnosis, because there's specific ways to treat it. Okay. Now, with frozen shoulder, that joint capsule, or that saran wrap around the ball and socket joint of the shoulder, becomes very inflamed, irritated, and it starts to develop basically scar tissue within the capsule. That scar tissue will loosen up with time, and as frozen shoulder, follows its typical path, but for a bit of time, it's very painful, and your shoulder is very, very stiff. Now, wondering who gets frozen shoulder? It affects about 2 to 5% of the population. Women are more affected than men, and that's at different multiples depending on what you look at. The average age is 50 for the onset. In Japan, they call it the 50-year-old shoulder. Ethnicity-wise, there's a higher prevalence in African Americans and Hispanic and Latino populations. And then as far as whether it will go from one side to the other, which is a question that we get quite a bit, it typically will affect one shoulder than the other in 6 to 20% of cases within 5 years. But it's very rare that frozen shoulder happens in the same shoulder twice. Now, frozen shoulder does follow a very loose pathway. Now, and we break it down into 3 stages. Now, the early stage is what we call the inflammatory phase. And that's when people have a lot of pain, but they can move their shoulder quite well. Okay. So this is when it can be difficult to figure out what exactly is going on. In the second stage, we start to see that progressive stiffness, and the patient's pain continues. Now, as we get into the later parts of frozen shoulder, we start to see some improvements in range of motion, but pain also really settles down. So we're able to do a bit more with the patient. Now, one of the difficult things with frozen shoulder is it is a very long, lengthy condition. Now, like the average length of frozen shoulder is about 30 months. So there's different things that you can do to give yourself the best possible outcomes and to make it no longer than it needs to be. But at the end of the day, it is a lengthy recovery. Now, one of the big things that I see often with physio and frozen shoulder is we get this inclination that it's stiff, so we need to stretch it. And whether that's in physio or just people coming in and saying, I can't move my shoulder, I'm stretching it like crazy, it's not getting any better. Early in frozen shoulder, we don't want to stretch it much, because the more we stretch it, the more inflammation we cause, and more inflammation turns into more stiffness and more scar tissue. Okay, so if we push it too much early, we're not doing anybody any favors and probably kind of lengthening the overall length of recovery. So early in frozen shoulder recovery, we're trying to just settle down as much inflammation as we can and avoid stretching to reduce stiffness. Later, when pain is really settled, we can do a lot more with hands-on treatment and exercise and different things. But early, when it's very painful, we want to really avoid causing too much stress on the shoulder. Now we'll jump into rehab. Now, there's a common cycle that we see when patients come in, and not just with shoulder problems, but with different issues. Something hurts, so we rest. So, maybe golf hurts my shoulder, so I'm going to take a couple of weeks off of golf. Well, by doing that, shoulder actually gets a bit weaker. So when we go back to golf or whatever the activity is, the pain comes back. So we rest a bit and we get weaker, we go back, and it comes back. Now, we try to break this cycle as much as we can. Sometimes avoiding activities and rest does play a key role, but we do have to build up some resiliency and strength in the tissues to have really positive long-term outcomes. Now, the ultimate rehab basics, when somebody has a lot of pain, we're just trying to calm things down at first. And one big mistake we see often is that we're trying to calm things down. We still can include exercise. We can still strengthen muscles and tendons when there's pain. It's up to your physio, chiro, or whoever you're seeing to come up with the right exercises for you to do at the right time so that it's not too painful and you actually have a positive response to the exercises. But exercise is really important even when somebody has pain. Now, if we look at both columns, whether we're trying to settle down pain or pain has settled down and we're trying to build up the tissues and build up more and more resiliency, we're doing a lot of the same things. Now, education is important. When somebody understands their injury and why it hurts, and if it's actually doing damage when something hurts, they're more likely to buy in and do the right things. Hands-on treatments or manual therapy can be helpful with maybe loosening some of the tight tissues, helping with make movements less painful, which can be really helpful. Taping can help with supporting the shoulder or getting your shoulder blade into a good position so you can continue strengthening and control pain. Activity changes. One thing, coming back to that rest concept, if there's an activity somebody really loves to do, we don't want to take that away from them and just avoid it to avoid pain. So a lot of the times we're trying to come up with ways to modify a task. So just as an example, if somebody loves going to the gym and squatting, and that's causing them lower back pain, well, we'll try and find a squat technique that's a lot more comfortable for them so they can keep doing what they enjoy, but just modify for a bit. Modalities we'll get into soon. Now, one thing in that calm it down column is medications. Sometimes anti-inflammatories, Tylenol can be helpful for pain. It's rare that there's much true inflammatory processes going on when somebody has rotator cuff issues. So sometimes anti-inflammatories don't help as much as they could. Cortisone can be another option too. Cortisone, the research isn't all glowing for rotator cuff injuries, but sometimes it's certainly appropriate and it's great to try. Cortisone can be very effective when somebody has pain, severe pain because of frozen shoulder. Cortisone is not going to fix the frozen shoulder, but it can help settle down some of the pain, which is obviously beneficial. Now, again, with rehab and looking at exercises, tendons respond best to heavy, slow resistance training. Now, that doesn't mean when somebody comes in, we start them on the heaviest weights in the clinic and they go from there. It's a gradual process. We come up with an individualized plan to get people there. But the truth is that if all you're doing is light, low resistance exercises for the entire rehab, you're not getting much of a response from the tendons. Okay, we need heavy, slow resistance exercises later in the rehab process in order to see true changes. So Really what we're trying to do is we're trying to slowly increase some of your strengthening and some of your mobility exercises, not not allowing pain to flare up, keeping pain at a manageable level, but slowly increasing your resistance exercises and your mobility exercises to keep building more strength and resiliency in the tissues, okay, and in the tendons. And that's how we get true changes. All right. It's very rare that with exercise or with movement, pain is damaging the tissue. Okay. There's other things going on that contribute to pain, but it's very rare that there's any more of a tear going on or damaging anything. Now, staying on that idea of pain, now this isn't a great selling feature, but when we're working on rehab exercises and we're working into strengthening, some pain during exercise is absolutely okay, and we kind of expect it. When we start loading tendons that are irritated, which is what they ultimately need, early in the rehab, we would expect anywhere from a 0 to 3 out of 10. All right. Now, I know everybody has different pain scales, but whatever your pain scale is, we're looking for a 0 to 3. Okay. That's early in rehab. We're actually okay with a little bit more later in rehab when we're getting into those heavy, slow resistance exercises. But early, we're trying to keep it fairly low, right? We always want pain to settle back down to your normal, typical levels within 24 hours of exercise. And pain shouldn't keep you up at night or shouldn't interfere with sleep. So for having problems where we're outside of these guidelines, we need to adapt what we're doing. We might have to do more hands-on treatment to settle pain down. You might be a good candidate for acupuncture, taping, different things like that. Now, looking at those modalities or adjunct treatments, like I talked about before, manual therapy can be very effective in helping restore more range of motion or less painful range of motion. Using ice or heat, that's a question we get all the time. There's no right or wrong answer between ice or heat. Ice is kind of coming under a little bit of scrutiny recently that it's slowing down the healing process, but it can be helpful if somebody has acute pain. So, maybe after a workout, just putting ice on for 10 or 15 minutes to calm things down. If you find that heat feels really good, heat can be effective as well. Shockwave therapy is something that we do for rotator cuff injuries. Maybe if they've responded to treatment, but we hit a plateau and we haven't got quite as far as we want to, it's trying to cause a bit of an inflammatory response and more blood flow to the tissues. So we wouldn't do this right off the bat if somebody had significant pain, but it may be something we do later on. Acupuncture and dry needling can be helpful too with pain control and trying to settle down some of the tone or tension in the muscles around the shoulder. Different current, so interferential current or IFC or TENS. Essentially what's happening with these two, we feel this tingle of the current, so it's helping distract us from the pain. So it's not fixing anything, but it can be helpful for pain control. And then, like I said before, tape can help support the shoulder. It can help pull or kind of remind us to keep the shoulder blade in a good position. So all these things are things that we can do at some point during treatment for people that it's appropriate for. All right, so my 5 favorite exercises. Now, I'll say right now that if you have shoulder pain and you start these exercises tomorrow, there's a good chance it might make your shoulder not feel great. These are good exercises for people without shoulder pain that are trying to keep their shoulders strong. They're trying to avoid shoulder pain. This isn't a rehab exercise program. It's not to say that these exercises don't regularly show up in my patient's rehab, but we don't start them on day one with these. We find individualized exercises. All right. So the ultimate physio basic exercise is external rotation. Now, with external rotation, we're trying to exercise 3 of the 4 rotator cuff tendons or muscles. Now, an important part here is we're trying to keep the elbows tucked in tight to your rib cage, not letting them flare out too far. I'm probably letting mine sneak out a little bit too far. So do as I say, not as I do. Another option is doing this, the cable at the gym. You can do it actually laying on your side with a small hand weight. So there's different options within this exercise. Now, another staple of shoulder physio is going to be internal rotation. Now, like I said, 3 of the 4 rotator cuff muscles externally rotate the shoulder. 1 of them internally rotates. So it's important to try to hit all 4 of those muscles. Again, I'm using an elastic here, trying to keep the elbow tucked in, but you could also use a cable unit at the gym, or one of those 2 options would be good. Now, this full can exercise. Now, I'm standing on a bit of an angle, so hopefully you guys can see I'm not doing a straight front raise, and I'm not doing a straight side raise or lateral raise as well. I'm leading with my thumb, so that's kind of lifting that full can, and I'm somewhere between lifting straight forward and it's to the side. So about 30 to 45 degree angle is what we're looking at, just lifting to shoulder height or slightly above, okay? Now again, you can use small weights at home. I always tell people, if you're just starting out, a half-liter bottle of water is a pound. So obviously a liter is 2 pounds or just over 2 pounds. So you can start with that, really simple. Now these rope face pulls are really good for strengthening the muscles around the shoulder blade, but also for working on external rotation. So when I'm doing these, I'm trying to get my elbows and my hands nice and far back. So not just pulling in like this. I'm trying to get that full external rotation as well. Now I'm doing it with a rope, which is something that you guys can find, at basically any gym. So I'm using a cable unit. Another option, getting a long resistance band. So you can either do 1 arm at a time, or if it's long enough and you're able to loop it around something, you're able to do 2. Now, the next exercise is one of my favorites, is a landmine press. Now, my hand is ahead of my shoulder, in front of my shoulder, and I'm pushing as far up as I possibly can. So you can see how I'm actually leaning into this a little bit and getting that extra kind of punch or push with my shoulder blade as I go up. Most of the time when we do overhead movements, we stop a little bit shy of that, and we aren't getting that good rotation and movement of the shoulder blade. So we're not strengthening the muscles around the shoulder blade. Another thing we hear often is when somebody's had shoulder problems for a long time, so they don't lift overhead. Then the reality is, at some point, they are going to have to lift overhead. So staying strong in that position is really important. The landmine press uses a barbell, and it's looped. It can be looped in or pressed into a corner or wedged into something. Another option, if you don't have a barbell in the setup, you can use just dumbbells ahead of the shoulder and doing a full press as far up as you can. Okay, so you can use small hand weights, or even something lighter around the house as well for these. All right. Okay. So that's it, everyone. So thanks a lot for watching. If you have any questions, give the clinic a shout. Our number is 519-358-7342, or shoot me an email, and I'll answer whatever questions I can that way. So thanks for taking the time to watch this, and yeah, hope to hear from you.